Good evening, all the aspirants. The class for today is Endocrine CCS session, class 2. And the speaker that we have here is Dr. Shraddha Patharkar. She is Associate Consultant at ABMH Hospital, Pune. Yes, ma'am, you can carry on.
So, we'll start with a case 40-year-old female liver transplant recipient on Visolon 20 mg and Pangraph. Cause for her live donor liver transplant was autoimmune CLD. Presented to ER in a drowsy state with decreased appetite, poor intake, generalized weakness, persistent lethargy, history of weight loss over past 6 months, and now complaining of occasional abdominal pain, nausea, vomiting. She had dizziness upon standing up, as she told. The family relatives told, and the patient gives a recent history of travel, upper respiratory tract infection also, for which she was treated on OPD basis. So, on examination in ER, her heart rate was 100 per minute, BP of 85 by 45, saturation 92% on room air. She was tachypneic 25 per minute. Mild basal crepes were present. Neurologically, she was E2 M5 V2. Her abdomen was soft, non-tender. On physical examination, we noted that there is hyperpigmentation on her palmar creases, knuckles, and oral mucosa. So, from this, just the history part and vitals, can anybody tell me what are the differentials? Patient with liver transplant recipient in a drowsy state with abdominal pain, nausea, vomiting, low BP. What is the commonest like possibilities in differentials that is coming into your mind? Forget about this as an endocrine class. It's just general case. So what you can think of from the
Patient can
history?
have ma'am.
Sorry.
Patient can have hypoglycemia, metabolic acidosis.
Yeah, but what from the case history, what she might have, why she had low blood pressures and
Addisonian crisis. Addison.
It's a post-op case, ma'am. Patient can have septic shock.
very good.
Uh, patient can have some myocardial infarction, acute myocardial event.
She has abdominal
Pancreatitis.
pain, nausea, vomiting.
Patient can
Pancreatitis.
uh,
So
if
acute gastroenteritis, hypovolemic shock, septic shock. From the history, it can be abdominal sepsis, it can be pancreatitis, acute gastroenteritis. So don't go to this adrenal insufficiency directly because you know this is endocrine. Clinically, the from history point of view, this looks like a septic shock in immunocompromised patient. So this the causes for the septic shock might be like from bacterial, fungal to parasitic, and you need to see whether it is a distributive shock, hypovolemic shock. So now you can tell that this is it looks like a septic shock in immunocompromised patients. We source might be abdomen because she had abdominal pain, nausea, vomiting, and but the physical examination is typical of hyperpigmentation on palmar creases. So it looks like adrenal insufficiency, also adrenal crisis. So when the ABG was done, the pH was 7.24, bicarb of 18, PaCO2 of 30, chloride of 114, sodium of 128, and potassium of 5.8. Can anybody interpret this ABG? Uh, can you see it now? Okay. Please read ABG. pH of 7.24, bicarb of 18,
So it
PaCO2
is
of 30.
metabolic acidosis.
Yeah. What kind of
No,
metabolic acidosis?
normal anion gap.
Very good.
With
What is the anion gap here?
anion gap now. Sodium is 121, chloride so 7.
Okay, fine. So it's
It is minus.
the quicker way to find it out is also look at the chloride. If there is a hyperchloremic metabolic acidosis, and bicarb is not that high, it is at 18. So whenever chloride goes up, bicarb should go down, and if the bicarb is not that low, probably you can guess it as just pure nagma. And even the here anything. What is the other abnormality? Electrolytes.
Hyponatremia and hypokalemia.
Yes. So can you give me
But
differentials of hyperkalemic metabolic acidosis?
Addisonian crisis is one, and
Yes, mineralocorticoid deficiency. You can call it as a mineralocorticoid deficiency, type 4 RTA, renal tubular acidosis, because of mineralocorticoid deficiency. Other possibilities being early.
Oh,
Yes,
yeah.
you can. Yes, because even they are aldosterone antagonists, so they also present like spironolactone, AC inhibitors, ARBs, LMWH, drugs related.
Thyrotoxicosis also can.
Sorry,
Thyrotoxicosis can cause hyperkalemia, I think, with hyponatremia.
I'm not getting it. All
Thyro-
potash
th- Thyrotoxicosis?
thyrotoxicosis. Uh, yeah, it might cause if it causes rhabdomyolysis. So even early uremic renal failure, obstructive uropathy, your long-standing CKD because of SLE, autoimmune glomerulonephritis, all of those, even the transplant rejection, all of these can present like this. So here what will be the next step? So anyways, I've written here. But whenever patient is presenting like acute abdomen in shock, so first we need to rule out the other differentials also, whether patient is having any pancreatitis or liver transplant, graft related some issues is there or not. So first and foremost, imaging what you will do bedside is ultrasound. So USG was done and it was suggestive of no hepatosplenomegaly, no ascites. Pancreas was obscured by bowel gas and the left kidney outlining was not appreciated. So see, this immunocompromised patients, you should not wait longer for imaging. So immediately when ultrasound was not showing anything, CT scan was planned. And meanwhile, you will send all the labs. What labs you will send? All the routine labs. Apart from that, what specific labs you want to know?
Cortisol level.
Yes, but unfortunately, patient is on Visolone, so that won't be a very accurate reflection of the underlying state. But still, yes, cortisol level is important. And see, here the adrenal insufficiency or adrenal crisis is because of whether it is an acute underlying condition or the chronic one. Patient is of autoimmune CLD. So patient might have autoimmune adrenalitis also. There is a possibility. So again, Addison's patient might be having Addison's disease, which was now precipitated, went into crisis because of underlying infection. So other so when there is autoimmune adrenalitis, is it a primary adrenal insufficiency or secondary?
ACTH stimulation test.
Yeah, but if okay, fine, you do ACTH stimulation test, and this is the result. Can you interpret it? So random serum cortisol of 7, what it indicates?
Not showing again.
Okay, can you see it now?
Yes. Yes.
So random serum cortisol level of 7 microgram per dl, what it indicates?
Can you
Normally,
show normal level, normal range?
no.
No,
I have not
show normal range,
like,
please.
see, patient is under a lot of stress. Patient is in shock. Patient is under a lot of stress. Normally, serum cortisol should be quite high. Whenever the levels are less than 7, 7 or less than 7, you can surely diagnose that as it's adrenal insufficiency. If it's beyond 20 microgram per dl, then it rules out your cortisol deficiency. But if it's in between, you have to rely on ACTH stimulation test. So your random cortisol level of 7, it indicates already low levels. With such a high stressful response of infection and shock, the levels are still low. When ACTH stimulation test was done, generally they do it with 250 mics of post-intropine, and after 60 minutes levels were rechecked and the cortisol level is 9. Initial was 7 and now the level is 9. So what it
Secondary.
indicates?
Secondary.
This looks like primary is aldosterone
No.
level is also low.
I think this primary because not increase from 7 to 9, not increase more. And another thing, hyperpigmentation will go with primary. Patient has hyperpigmentation in the palm.
Yes, very good. See, the ACTH stimulation test, what it indicates is there was no increase in a cortisol level to the ACTH challenge. Normally, ACTH should stimulate adrenals to produce cortisol. But here there is a problem in the adrenals. That's why we have given ACTH externally. And still there is no increase in the cortisol. It means primary pathology is in the adrenals. And here the ACTH level is normal. 5 to 52 is normal range, and here patient is having 15. So when the ACTH is normal means secondary pathology is ruled out. Either in primary adrenal insufficiency, when the adrenals is the problem and the pituitary hypothalamus, they are not a problem. Either the ACTH should be high, ideally it should be very high, or it can be normal also, depending upon whether this autoimmune disease has affected pituitaries also. But definitely low ACTH indicates secondary reason. Low ACTH means pituitary is not producing enough ACTH, and that's why adrenals are not stimulated to produce cortisol. This is very important because this will come as a in CBS also. There are you need to get this concepts clear. So in primary adrenal insufficiency, ACTH is mostly high, but if associated autoimmune pituitary problem is also there, it might be normal. But pure secondary adrenal insufficiency, ACTH should be low. So again here aldosterone level is also low. What it indicates?
This indicate primary.
No, I mean it indicates the whole gland is involved. It's not just the glucocorticoids, but the aldosterone levels are also low. So it's a primary disease. Mostly in primary
Yes,
adrenal insufficiency, when there is a
Glucocorticoid and
secondary
mineral
problem.
corticoid.
Sorry?
Glucocorticoid and mineral corticoid. Aldosterone is the low.
Yes.
Isn't it
Both are low.
Oh.
Yes, both are low means entire gland is involved. When ACTH, if the problem is only with the ACTH, generally glucocorticoids should get affected. It's when it is this helps in differentiating primary versus secondary. When there is a mineralocorticoid deficiency also along with glucocorticoid deficiency, it's a primary. Whenever there is a hyperpigmentation and ACTH high, it is primary. And even the electrolyte abnormalities, that if it is In our case, there is a hyponatremia, hyperkalemia. It also indicates it's the primary cause for the adrenal insufficiency, and it might be chronic adrenal insufficiency. So chronic adrenal insufficiency, because of commonest cause in developing country is tuberculosis. In developed countries, it is autoimmune, and this patient had autoimmune CLD that led to transplant. Probably other autoimmune associations is also common. So Addison's disease is the possibility in this case. Young patient. But again, he has a history of weight loss. So even tuberculosis, we need to keep that in mind. If elderly patient with history of weight loss, similar situation, you have to consider malignancy, paraneoplastic syndromes. So your case might come as any it may come in any way. So you need to know the differentials. What can lead to primary adrenal insufficiency? So whether many a times it is the chronic condition precipitated by triggers. In our condition, trigger was infection, started with URTI, upper respiratory tract infection, and crisis patients present with abdominal pain and nausea, vomiting. So they mimic like gastroenteritis, or gastroenteritis itself can precipitate adrenal insufficiency. Either of the things is possible. So you need to know the differentials, etiology, risk factors. Another being secondary pituitary problems might be because of again malignancy, pituitary tumors, neurosurgery. Acute adrenal crisis is little rare, and which occurs because of, if it is a primary, it is because of the hemorrhages in adrenals. Waterhouse Friderichsen syndrome, and it is also a type of, it's most commonly in meningococcal septicemia. Because of the sepsis, microvascular thrombosis occurs in the adrenals, and later that converts into hemorrhage. So that is the reason for acute adrenal loss or insufficiency. Another cause for acute adrenal insufficiency secondary is pituitary apoplex. That is acute in pituitary infarct or hemorrhages post PPH, traumatic PPH or atonic PPH. If patient is presenting like adrenal insufficiency, that might be the acute cause. And in all the chronic causes, there will be some precipitating factor that pushed patient into crisis. This is very important to understand. What are the chronic causes? What are the acute causes? What are the primary causes? What are the secondary causes?